thank you for joining us for part 2 of our CTEPH and U webinar series. The topic this evening is how is CTEPH diagnosed? And just a reminder that the information presented on this webinar are for general informational purposes only. Don't rely on this information as actual professional medical advice, care, or treatment, as this webinar is not designed to and does not provide medical advice, professional diagnosis, opinion, treatment, or services to you or any individual. I am now honored to introduce Dr. William Auger, who worked closely with NATF to design this webinar program and who will introduce this evening's faculty. Dr. Auger.
Well, thank you very much, Catherine, and thank everybody for attending this webinar this evening. I am thrilled to introduce our faculty for tonight, Dr. Gustavo Heresi and Dr. Anjali Vaidya. Now, these, my opinion is that these are two of the best educators in the field of chronic thromboembolic disease, and I really thank them very much for joining us tonight and heading up this webinar. I'll start first with Dr. Gustavo Heresi, who is the director of the Pulmonary Vascular and CTEPH program at the Respiratory Institute of Cleveland Clinic. Dr. Heresi's clinical interests are in pulmonary hypertension, acute pulmonary embolism, and CTEPH. He's an assistant professor of medicine at the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University. And Dr. Anjali Vaidya is the co-director of pulmonary hypertension, right heart failure, and CTEPH program at Temple University Hospital. She has extensive experience with thromboembolic disease, pulmonary hypertension, right heart failure, right ventricular disease, which is the reason why I consider her the premier RVologist in the world. Valvular heart disease, cardiomyopathies, cardiopulmonary diseases, heart transplant, and congenital heart disease associated with pulmonary hypertension. Thank you so much for the both of you for being here tonight and sharing your wisdom with patients who've experienced recent pulmonary embolic events. Thanks, guys.
Thank you so much. Good evening, everybody. And thank you, Bill and Catherine and NATF for hosting this event. And thank you all for attending. So we're going to talk about how we make a diagnosis of this condition called chronic thromboembolic disease. I know a few weeks ago, you guys talked about a little bit about the disease and the risk factors and so forth. So we're going to hone in into how your doctors may be able to diagnose you with this problem. So just to refresh everybody, we're talking about a condition that we think starts with a clot and it becomes a scar that you can see there in this cartoon. This scar doesn't allow blood flow, and so you have high lung pressure in the pulmonary arteries. This puts a strain on the right side of the heart, and this is the reason why people have trouble with this condition. All the testing that your doctors may do is really geared towards finding two main things. One is where and how much chronic clot you have, and two, how much lung pressure elevation you have. Because the disease is basically high lung pressure due to chronic clot. So all the testing that we'll talk about tonight, it's really geared towards finding out those two things, chronic clot and lung pressure. And this is just a visual representation to the left of your screen of what a fresh or acute clot looks like. And you can immediately see how different it looks from a chronic clot, which is really more like scar tissue. And so I show you this just so that you understand, or at least imagine, how different these clots look like on the testing the doctors do, and why sometimes it's a bit difficult to pick up the one on the right, the one that looks like scar. When we think about who may be at risk for this condition, and I know you guys talked about that last time, but just to emphasize a few things, the main setting is folks who have had a chronic clot, a prior clot, either in the legs or in the lungs. But when we think about hypercoagulability, meaning, people frequently ask why the clots, where did they come from? Why do I have these clots? Why I am not able to clear them away? The truth is that we really don't know exactly why this happens. And also, when we test for the conditions that we know lead to clots, very rarely we find such conditions in people with chronic thromboembolic disease. The one in the red bar, the lupus anticoagulant antibodies, is perhaps the main hypercoagulability disorder, meaning that blood disorder that predisposes to clotting. That's the one that when we test for these conditions, we tend to find. But the vast majority of folks, when we test for conditions that predispose to clot, they actually don't have it, and this is really not a surprise. But so how do we see people presenting with this condition? Perhaps one of the classic stories is you have a clot, you had shortness of breath when you had a clot in the lung, and then there's a honeymoon period where you feel a little bit better. But then after that, shortness of breath comes back or starts to get worse again. That would be the most common presentation. Sometimes people cough up blood, but this is really not that common. And then sometimes people present with bloated bellies, fluid retention in the legs. We really want to find this condition prior to it doing that. So when you have fluid retention, the condition is a bit advanced. But one thing that's important to remember is that I told you about how we think this starts with a clot, and we're pretty certain that that's the case. But very frequently, our patients, no matter how hard we ask them and how hard they think back, they cannot really tell us that they had an episode of clot in the past. And so even if you didn't have a clot in the legs or in the lungs in the past, this condition certainly happens. And so the absence of a history of a clot in the legs or the lungs doesn't exclude this diagnosis. But at the end of the day, this condition is very difficult to diagnose. I told you about shortness of breath, but a lot of things cause shortness of breath. I told you about some physical findings like swelling and whatnot, but those are really late and early on. The physical examination is really normal or very subtle. I mentioned already how a history of clot is really not required. You can have this condition and never had a history of clot in the past. And for all of these reasons, frequently this condition is misdiagnosed by other things. People are told you have asthma, you have COPD, maybe you're overweight, you are maybe out of shape. And so doctors frequently don't really recognize this disease as the reason for shortness of breath. And in part is due to lack of awareness. This is not a condition that you really sort of learn a lot about when you go to medical school. Clearly, events like this are geared towards sort of raising the awareness, and I think that has gotten better over time. But these are just some of the challenges in terms of picking up this condition. And this is why people like Anjali and myself, we would always think about CTEPH in three sort of patient populations, in three groups. One is anybody with pulmonary hypertension. If you have a diagnosis of pulmonary hypertension, you need to think and ask your doctor about some of the testing that we're going to discuss in a minute. Second is anybody with shortness of breath who had a history of a clot in the past. And finally, quite frankly, anybody with shortness of breath where there is no obvious reason, we like to look for this condition because it's often not picked up by regular testing. All right, so now I'm going to just show you a few examples of how the testing looks like, and I'll explain what they are. The first test, and the one that you will hear over and over again, is the so-called VQ scan, or the ventilation perfusion scan. This is a nuclear medicine test. You get injected a substance that emits a signal that then we pick up with cameras, and then we create this image that I'm showing you there. This is the key part, actually, the perfusion part. This talks about blood flow. When this test is normal, and this is a normal example, all nice and smooth, no areas of darkness, these pretty much exclude chronic blood clots in the lungs. So if you have a test like this, a perfusion scan, lung scan, or VQ scan, and that test is normal, you can be, and your doctor as well, fairly certain that you don't have chronic clots. On the other hand, if you have, and again, you really need to know exactly what I'm showing you, but this is an example of an abnormal test. And in this case, I'm showing you here both the ventilation part and the perfusion part. And if you look carefully in the first row, for example, you see an area of whiteness without perfusion. That would be a sign that potentially you're dealing with a clot obstructing blood flow. The ventilation part is very useful as well. If we see normal air getting into the lung, that is more consistent with clots as the reason for the abnormalities. I show you this because during the last couple of years, a lot of our centers stopped doing the ventilation part because that means inhaling a substance that can rattle things. And in the era of COVID, we were concerned about disseminating COVID. But luckily, we've learned over the last couple of years that, again, doing just the perfusion part may be enough. Your doctors may also do some more sophisticated perfusion pictures. I'm showing you this, where we add a little bit of a CT, and then we fuse these images on an imaging station, and we can create these beautiful color images where the bright colors means normal lung flow. The dark areas show areas without blood flow. So basically, a perfusion scan is the first test. If it shows areas without blood flow, then you need to think about the next steps to determine whether or not clots are the problem. After the lung scan, if it's abnormal, your doctor is very likely to order a CAT scan of the chest with the administration of IV contrast. You'll get a different type of contrast injected into one of your veins in your arm, typically. Then you go through the scanner, and then we can take these pictures of the pulmonary arteries. And basically, in this kind of test, when it's white, it's okay. But in the middle, you can see where the arrow is pointing an area that's occupied by gray stuff. That's an acute fresh clot that over time, to the right on this slide, it looks now narrow and small. And that's what scar does. I hope you remember that a clot looks big, and then as it scars down, it shrinks. And this is an example of what the CAT scan looks like with a chronic clot. These are just other examples, and just to say that the CAT scan really shows chronic clots very nicely, but it requires special experience and expertise to pick up these chronic findings. And so sometimes if your local doctors are able to connect with centers like Anjali's, for example, or mine or Bill's, so centers that have a lot of experience looking at these scans to find chronic clots, that's always advisable. And our centers are always happy to even just take a look at these scans before you come to see us. The CAT scan provides a lot of other information to your doctors in terms of how the lungs look and other signs that are pretty suggestive of chronic clots as the reason for your shortness of breath. So the CAT scan and the perfusion scan are allowing us to make this diagnosis in a lot of cases, not all of them, but a lot of cases. We and many other centers are also sort of, trying to understand how technology can help us, help you guys, help our patients. And now with CAT scans also, we can create these kind of pretty looking imaging pictures of blood flow. So a scan that can put together the anatomy and flow. This is something that we're doing, but again, we put everything together. We put the perfusion scan and the CAT scan information together. at the end of the day, the reason we do all this testing and some of the other testing that you're going to hear is because a lot of the times, even if the perfusion scan is abnormal, there are other conditions that can look like that, but they are not necessarily CTEPH. Some of them are listed here. Some of them are rare, but depending on where you live, some of these conditions are actually relatively common. The point here is that it really requires a lot of experience and expertise to be certain that chronic clots are the reason for pulmonary hypertension. You want to make sure that you don't confuse CTEPH with some of these other conditions like sarcomas or sarcoidosis or even cancer, because the treatment, of course, for all these conditions is very, very different. So it's always advisable to have a conversation with your doctors, have them connect you with a CTEPH center, a center with experience and expertise in looking at these pictures, just to make sure that you get the right diagnosis. And this is my last one, and I like always to show this because I always tell people the reason we do all of this testing, and sometimes it seems like a lot and long days, is because we really like to sort of corroborate the information from the perfusion scan, from the CAT scan, from the pulmonary angiogram that I'm showing you here, that Anjali is going to show you more examples of. Because the more consistent information we get, the more confident we are of the diagnosis, and also the more likely you are to benefit from the way we treat this condition, which frequently involves an extraction of these chronic scars. This is my last slide, and Anjali is next. Thank you.
Great. Thanks, Gustavo. That was wonderful. I'm really excited to talk to everyone today and to finish out the last portion of this before we do our Q&A. And thanks again to Catherine and to Dr. Auger and everyone from NATF for having me. I'm just going to build off of what Gustavo was talking about, the diagnostic testing. And he mentioned wonderfully early on that we're focusing on blood clots in the lungs and the pressures that are high as a result of that. So that kind of segues nicely into the ultrasound of the heart, which is the echocardiogram. And this is a test that can provide a lot of information to your team of doctors that are interpreting it. There are so many different things that we can assess from the echocardiogram. What I've put in red, I'm going to start with, because the pulmonary pressure estimation, that's the PA systolic pressure or the RV pressure, that is what often originally brings suspicion to your doctors that, hey, there might be pulmonary hypertension here because there's an estimation of a pressure that's on the higher side. And that is really important in an initial screen, an initial evaluation. But the reason I'm saying there's less emphasis on that is because as we sort through getting to understand what's going on with our patients, we actually look at many more features of the heart specifically. And what I've included here are some examples. On the top of the slide, panels A, B, and C are really abnormal. And on the bottom, D, E, and F are normal. And just some examples, just start in the middle panel, B and E. That just shows all four chambers of the heart. And at the kind of top left chamber, I don't think you can see my arrow on this slide, but thank you. That's the right ventricle. That's what we're focusing the most on. And it's really big in panel B, and it's much bigger than the left ventricle, which is next to it. And it shows that the muscle is really thick. It's hypertrophied, which means it's been working really hard against a high pressure for a long time. And the shape of it, so I mentioned what we call the RV to LV, right ventricle to left ventricle ratio. We can see backwards flow across that tricuspid valve. That's tricuspid regurgitation, or TR. We can look at the ratio of the base, the bottom of that chamber, towards compared to the apex, which is the very top of the picture there. That ratio changes when there's significant pulmonary hypertension. In panel A, it looks like the letter D compared to that donut underneath it, that round symmetric circle, and that flattening of the letter D right there that you can hopefully see on the screen also gives us evidence of high pressure, high stiffness in the arteries of the lungs from the clots that have been there for a long time. And then I mentioned on the slide, you can see the word RVOT Doppler notch, which you do not have to memorize, but it's just a picture on the panel C there, which is just a way that we can see when we look at the pictures of the ultrasound of your heart, that there's a lot of stiffness in the arteries of the blood vessels of your lungs. And it's just creating this abnormal shape and this abnormal pattern in the blood flow pattern as the blood is trying to leave the right side of your heart. Because as you know, the blood from the right side of your heart is what's trying to then travel through those blood vessels of the lungs and the lung arteries, and it can be limited and impaired by chronic blood clots. So when we look at the ultrasound of the heart, we're looking for size, shape, structure, and function of the right side of the heart, with a lot of these hidden and subtle clues to give us evidence that these blood clots are really causing high pressure and strain. This is just an example of ways that we have tried to help all doctors that are out there to recognize signs of pulmonary hypertension a little bit easier. So Gustavo really nicely mentioned earlier that awareness and teaching of pulmonary hypertension of all forms, including CTEPH, is not as standardized and common, although we're making strides on that. And so this is just an example of ways for doctors that may not have the awareness and the experience and the expertise to look at routine echoes that have been done, echocardiograms and ultrasounds, and look at the reports of those ultrasounds and use some clues that are hidden but in plain sight on the routine echo reports that estimate pressures on the left side of the heart and give clues of stiffness of the arteries of the lungs too, so that if it scores a certain way based on some of these features on the ultrasound of the heart, it can really raise suspicion for your doctors sooner rather than later that, wait, this patient might be short of breath because they have CTEPH, chronic blood clots in the lungs, or a similar form of pulmonary hypertension. One of the next tests that has for so many years been considered sort of the gold standard for measuring pulmonary hypertension is the procedure called the right heart catheterization. And what I've shown here is the original publication that came now 52 years ago. And it just shows, I like to show the picture of the catheter itself that goes into the heart and lungs through the vein. And this is the catheter on the top left of the screen. It looks sort of, as I tell my patients, kind of like a long spaghetti noodle. And in the panel E on the bottom middle of your screen, there's a balloon oh, sorry, go back one slide. There's a balloon that blows up at the tip of the catheter. And this catheter that you're seeing goes into the vein and into the chambers of the right side of the heart, the pulmonary artery, and measures the pressures throughout all of those chambers and blood vessels. And on the right side of the screen are the tracings that give the estimation of those pressures. So the right heart catheterization is a procedure that's done to directly measure, not estimate like the echo, but directly measure not just the pressure in the blood vessels of the lungs, but to tell us, your doctors, how severe it is and where it's coming from. Is it coming from stiffness of the arteries of the lungs? Or is there a problem with the left side of the heart that's stiff, which can also be very common? And we use these numbers to calculate additional portions like the function of the heart and how much blood flow your heart's able to generate, and things that really give us more in-depth information of the impact on your heart function from the blood clots in your lungs. So this right heart catheterization, which we've been doing in this manner now for over 50 years in medicine, has evolved not just in its use and its awareness, but some of the nuances of how we interpret it. This is just an example of an article that came recently in the literature showing some updates in how we interpret the cardiopulmonary hemodynamics in pulmonary hypertension and all forms of heart failure. CTEPH is a form of pulmonary hypertension, which is a form of heart failure. And what's shown in this image here, if I just draw your attention to the right side of your screen, is where it says contemporary model pulmonary hypertension assessment. It just shows how we're using initially in the middle here, taking a patient who has shortness of breath, that's dyspnea, they have some evidence of heart failure, some unexplained abnormalities on the right side of the heart. And this is a guide that we published to teach providers and physicians to use the right heart catheterization early. As Gustavo was saying, let's not wait for patients to be really sick. Let's do it early and let's use the best technique, which I'll talk about in a moment. And on the bottom, it just shows there are a lot of different combinations of how these numbers could look that reflect not just the pressure in the lungs, but the stiffness in the arteries of the lungs, how the left side of the heart is functioning, and different combinations of how these numbers might turn out can mean very different things for an individual patient. And believe it or not, patients that have CTEPH can have a broad combination of how these numbers might turn out as well. And so it's a guide to help interpretation of what can often be a complex set of numbers. I mentioned the technique earlier. So this procedure has been around for many decades, as I mentioned, but what we've learned as we've become more experienced in CTEPH and in pulmonary hypertension is the technique of obtaining numbers is actually not very straightforward. So all I've shown you here is just some examples that I hope look very different to you of these tracings on the screen. And in fact, they are very different, but done with different technique. The same patient with the same numbers can give very different appearance of these tracings that the procedure kind of offers to us as your doctors. So when I'm in the cath lab, myself and Gustavo and all of our colleagues around the country who do this for a living need to really pay really close attention to the technique and make sure that we're getting accurate numbers so that we can give you the correct diagnosis to help guide our plan. And finally is the pulmonary angiogram. And this is done at the same time of the right heart catheterization, where the catheter goes into the pulmonary arteries. This is the right lung on the left side of your screen and the left lung on the right side of your screen. And the dark color there is the contrast that is filling in the pulmonary arteries. And the gray sort of blank areas on the edges of both lungs are areas that are not getting good blood flow. And that's from chronic blood clots. And the arrows here, the white arrows just show total blockages of those blood vessels. The red arrows show the narrowing of the blood vessels that then lead to abnormalities in the shape and caliber of the blood vessels after those narrowings. The blue arrows on the right side of your screen show some abnormal chronic clots within the blood vessels that have partially reopened again. But these abnormalities can often be very subtle and very challenging to interpret. And the technique of performing this pulmonary angiogram is also very complex to get adequate diagnostic information. And so, as Gustavo was saying, the recommendations are to have these procedures and testing done and interpreted at expert centers for CTEPH, because it can make all the difference in accuracy of diagnosis. This slide just shows a couple other examples of blood vessels and the clots that are in them, and just the different characteristics and way that they can be blocked either completely or partially and all still fit with the diagnosis of CTEPH. Finally, this is just the last example of pulmonary angiography, which we won't get into too much detail, but just to show that in addition to those angiograms, which are the X-ray-like pictures, next to that, you can see these bright colored combination of advanced techniques that we often will use in the cath lab: optical coherence tomography, fractional flow reserve. So more advanced ways of imaging those blood vessels, as well as measuring pressures across each narrowing. And that can often be part of our diagnostic assessment to help guide therapy, not just surgery, which is a big part of the treatment, but also something called balloon pulmonary angioplasty. And for the final portion of the diagnostic testing, Gustavo really nicely talked about medical conditions, things that make your blood clot more severely. And I just want to touch upon sort of a newer category of risk that I call the mechanical risk factors for CTEPH. And this refers to things that can happen in our abdomen or in our pelvis that actually block the big veins in our body, whose job it is to deliver blood flow back to our heart. And if we're compressing those veins, it can make it much more common and make us a higher risk to develop clots in those veins that are being compressed. And so I'll show you some examples of what I mean. This is uterine fibroids, which might sound completely unrelated to blood clots in the lungs, but these are just examples of, this is our cartoon of a uterus that has these benign tumors called fibroids. And on the other side of the screen is a more advanced imaging picture, and you can see these big kind of globs in the uterus. And you might imagine if they're so big, they can put pressure on the structures around that. This is just a publication from our observations in our program at Temple years ago, where we said, hey, we have a lot of women that have blood clots in their lungs, but it's unprovoked, and we can't understand why. They don't have that clotting disorders that Gustavo mentioned. It turned out almost 1 in 5 of them had large fibroids in their uterus And it wasn't known before that that might be a risk or a link. And when we looked more closely, it showed that those fibroids were compressing the veins. Subsequently, the patients went on to have their uterus removed or the fibroids removed. And it actually seems to potentially help reduce the risk of recurrent blood clots. This is just some pictures showing how the narrowing of the blood vessels in the veins were present when the fibroids were compressing. And on the right side of the screen, just more examples of really big benign tumors. And we think about women having them and how it can cause bleeding or discomfort, but really important to just know in the back of our minds that it might also make women at risk for developing blood clots in their legs that travel to the lungs. And then finally, this is just another category of mechanical risk of blood vessels. This is a paper we published last year looking at something called May-Thurner anatomy, which is a congenital variant that a lot of people have. And this involves the vein in the left side of the pelvis. It's called the iliac vein. And this arrow is pointing to it. And it just shows some compression from an artery that runs right alongside it. And that compression we have diagnosed and noticed there's a really high rate of this being present in patients that have gone on to develop CTEPH compared to patients that don't develop CTEPH. So we found this association, and we thought this was an important thing to be aware of. And in fact, we noticed in patients in our CTEPH program at Temple, when we found this May-Thurner anatomy in the cath lab, when we did testing, that venogram, they were more likely to have blood clot in their left leg, which went along with it. And a lot of our patients tell us they've had recurrent clots in their left leg. And because those clots are often quite big, because those veins are very big, they travel to the lungs and they can really cause significant blockage in the big arteries of the lungs. And as a result, the patients that have this May-Thurner anatomy were more likely to undergo that surgery, that PTE surgery, pulmonary thromboendarterectomy, to remove those blood clots. And finally, the last thing I want to show you is a bigger category of what we're calling sort of pelvic vein obstruction, which is similar to that May-Thurner anatomy, but just to be aware of the fact, as you can see on the left of the screen, that's just a cartoon of all of the veins that lead up from the legs up into ultimately to the heart. And there are so many branches and levels at which there might be narrowings or blockages. And we've seen quite a bit of that in our diagnostic testing. So to add to all of the chest imaging that Gustavo told us about, the CT, the VQ scan, the blood tests and more, there's the echocardiogram, which is the ultrasound of the heart, the right heart catheterization to measure the pressures and flows, the pulmonary angiogram to look more directly at those blood vessels in the lungs, and then finally, being aware of and testing and looking for some of these mechanical obstructions that can also lead to CTEPH. We'll just summarize here with some key points. That, as you can notice, the diagnosis of CTEPH is quite complex and it requires many factors for an integrated clinical assessment. The clinical history and symptoms are very important in the diagnosis. We mentioned the VQ and CT angiography, really important to tell us about the clots and the blood supply to the lungs. The echo and the right heart cath tell us about the severity of pulmonary hypertension and the impact on the heart. And the catheter-based pulmonary angiography can further demonstrate thromboembolic disease. So I think we'll stop there and open it up to any questions. Thank you very much.
Thank you guys so much. That was a wonderful presentation. If you're concerned about having CTEPH, who should you go to for these types of, diagnostic testing? A pulmonologist or a cardiologist?
It really, the answer is more, who's the pulmonary hypertension expert that's close to you? Where we are, it's going to be cardiology. Where Gustavo is, it's going to be pulmonary. I think that whether you're cardiology or pulmonary, you just have to find pulmonary hypertension experts because there's a lot of overlap there and it's not specific to either field. But then even within that, pulmonary hypertension expertise is already few and far between. I think Gustavo would probably agree. We're trying to improve that across the country. But even within that, CTEPH expertise is even much less so. So I think it starts with the pulmonary hypertension expert to recognize this possibility, and then a quick referral to a CTEPH expert, which might be cardiology or it might be pulmonary.
Okay. Great. So, and then the next question is just kind of asking something, Gustavo, that you had touched upon, that you don't need to have a pulmonary embolism necessarily to develop CTEPH. So can you talk a little bit more then for chronic thromboembolic pulmonary hypertension, if they don't have to have a history of PE, kind of where that thrombotic part comes in?
Yeah, and so I think that observation, which is very consistent sort of across many years of experience, has really a really practical implication, right? So for the audience, the practical implication is think about CTEPH or discuss with your doctors about CTEPH if you have shortness of breath, tiredness, or other symptoms, even if you didn't have a history of PE or DVT. That's really the key point, because we do see CTEPH in people that we ask very hard and they really will not tell us that they had a prior PE or DVT. Now, there are a variety of reasons behind that. As you may know, sometimes people have clots and they don't really notice them. Mm-hmm. Sometimes they have clots, a PE, and it goes misdiagnosed by something else, for example, an asthma attack or pneumonia. So it's possible that some of our patients that don't tell us a history of PE, they did have it. It's just that it was not recognized. Okay. And then, there are some CTEPH patients that indeed may not have had a history, just the disease develops for reasons that we don't understand. But from the practical perspective, the point to you and to your doctors is do not exclude CTEPH if you don't have a prior history of clot.
Okay. So if you do have a history of, blood clots and you have, shortness of breath, how, proactive should you be about mentioning this to your physicians to kind of warn them about, kind of potentially developing or thinking that you might have CTEPH?
I would say very, very proactive, right? So I always emphasize that the first part that we discussed, but the reality is that if you had a history of DVT, PE, of clot, one or more, but certainly one is enough, and you have shortness of breath, CTEPH needs to be sort of there at the top of the list as a reason for shortness of breath. Not necessarily because it may be the most common one, but because it's the one that may be more serious and the one that we can really do a lot for. We can remove those clots with surgery, we can put balloons, we can use specialized medicines. Mm-hmm. So I think that if you have shortness of breath and you have a history of DVT or PE, definitely ask for that lung scan, talk about CTEPH with your doctor. As Anjali was saying, discuss the possibility of a referral to a center with expertise in pulmonary hypertension and CTEPH. It really has to be very high on your list. But I will emphasize that shortness of breath and a history of PE or DVT does not equal CTEPH, right? Our patients still can have other things, COPD, heart disease for other reasons, etc.
Okay. I'll add, I agree 100%, of course. And one thing that you reminded me of, Gustavo, is sometimes patients have had a known prior PE and they might be more short of breath again in the future. Mm-hmm. And then they're diagnosed with another new or acute PE. And so we call that like recurrent PE or repetitive PE. And then often told that the blood thinner that they were on kind of failed them and it didn't work enough. And then they're switched to another blood thinner. So this is a story we hear several times a month. And I just want to mention that because very often when that is the perception of what's happening, when a CTEPH program, a CTEPH doctor looks at those pictures of the scans of the lungs, it turns out that the patient just had chronic clot the entire time that was sort of getting worse or not going away or progressing. And so, but the patient might feel, oh, I'm suddenly short of breath and it's worse and it's worse. It's not always just a new fresh clot or that the blood thinner didn't work. It's very often that it's been chronic for a long time.
Okay. Interesting. So kind of that, I guess, honeymoon phase that you were talking about earlier, Gustavo, about how maybe patients feel okay initially, but then it might get worse, the further out they get. Yeah. So a lot of the the tests that you talk about have scary names and sound, like what, somebody sticking something in my heart. And, Gustavo, if you wouldn't mind talking a little bit about kind of what the patients can expect when they undergo, some of the imaging procedures that you talked about. And then, Anjali, if you could talk about, what patients can expect, with some of the more invasive procedures that you discussed. And obviously, we don't need to go into great detail about every procedure, but just kind of generally, what can patients expect?
Yeah, no, this is a really important point, Catherine. There is a misconception that particularly the lung scan may be too risky in folks with very high lung pressures. And that is not true. So I think that luckily it's becoming less and less common, but we still hear sometimes the people say, the lung scan, your lung pressures are too high. We shouldn't really get a lung scan. It may be risky. It's not. Actually, this test is very safe, very well tolerated, minimal radiation. The substance that we use to get the pictures goes away over time. It doesn't injure the kidneys or anything else. The CAT scan uses contrast that can injure the kidneys, although the current modern versions do it much less than before. But if you have very severe advanced kidney disease, that may be an issue. Allergic reactions to contrast are exceedingly rare, very, very rare, but they do happen. So certainly, if you had a prior bad experience, certainly bring it up. But we're frequently able to do a CAT scan with contrast, even if you had a minor reaction in the past. So the imaging studies that I described, in general, very safe, very well tolerated.
And those are typically outpatient procedures, or?
These are outpatient procedures. You come in frequently, to make things easier for people. You come, you get them in the morning, and you see us in the afternoon or the day after. You come in and out. Yeah, these do not require hospitalization or anything like that.
Great. And for the testing that I mentioned, so I started with the echocardiogram. That's easy peasy, no IV. It's just ultrasound goop, like gel on your chest, is sitting in the dark with the probe being pushed on your skin that might feel some pressure. But it's no risk and outpatient and, no sedation. The cath is probably what you want to know more about. So the right heart catheterization, this is also typically an outpatient procedure. And importantly, it's not a cardiac catheterization where we look at the coronary arteries or we inject contrast routinely for the heart cath itself. The part that measures the pressures and flows is just that catheter through an IV that goes through a vein. And that vein is sometimes in the neck, it's sometimes in the arm, right around here, or it could be in the groin, right kind of next to your hip. And they numb you up real good with some local numbing medicine and put the IV in. And then the catheter itself, you don't feel that part. All you feel is sort of the numbing medicine and a little pressure with the IV going in. The pulmonary angiogram that happens often in conjunction with the right heart catheterization, once you're further down the road of the diagnostic testing, that is often done through the same IV, either in the neck or in the hip, in the groin area. And that is through just a different catheter, and that's where the contrast is injected. So it's no more sort of sedation or additional needles, but it's just makes the procedure a bit longer. And the contrast is injected, and it's the same contrast, similar concept to what you would have in the CAT scan that Gustavo was mentioning, and it may have some effect on the kidneys. And then I mentioned the venogram when we were looking at those mechanical obstructions in the veins. So that's the same exact technique as the pulmonary angiogram, but just directing that contrast to a slightly different blood vessel in the body, but that's done at the same time as the pulmonary angiogram.
All right, great. So I think both of you at some point mentioned really how, especially rather than seeing, are you seeing a pulmonologist or a cardiologist, it's more important to make sure you're seeing a CTEPH expert as you're kind of exploring this. So are there any particular questions or any advice that you can offer to patients kind of as they start this initial, journey into, a potential CTEPH diagnosis in terms of finding the right clinician or, the right center to see? Anything that they should really ask about or keep an eye out for?
Yeah, what I would say, and I was thinking about that when you guys were talking about a similar issue earlier. I think that the key point is for folks to be an advocate of themselves, right? Particularly if you had a history of a prior clot, leg, PE, and you have shortness of breath. I think this is something that you need to discuss with your doctor, whoever that may be, whoever is taking care of you right there, your primary care, your family doctor. So say, listen, doc, I have this history, I have shortness of breath. I heard about this rare condition called CTEPH. Can we talk about it? Should I be tested for that? And if not, do you know somebody close by that, can take a look at me to look into that? So never assume that your shortness of breath is due to asthma or weight, or I'm simply out of shape. I think it's fine to sort of think about those things early on. Maybe they give you an inhaler. But if you try all of those things for a couple of months, you try to get back in shape, you try an inhaler, you try something, and it doesn't work, then clearly you have to advocate for yourself. Talk to your doctor. I may have chronic clots. Let's get some testing. Let's talk to somebody. And again, I think Anjali, I'm sure, is the same. Centers like ours, we get phone calls, and we're always happy to even just take a quick look at pictures, just to give an initial sense to folks as to how important it is for them to travel to see us and so forth.
Yeah, Gustavo is exactly right. Your local doctor, who's very well-meaning and cares a lot about you, may be able to do an initial scan, like Gustavo was saying, to say, looks like maybe blood clots, but once you get at that possibility, he's right. Be your advocate for yourself. And, for perspective, we have patients from, 23 states have traveled to our program, and similar experience Gustavo has, and Bill has led the way for many years. And just for perspective, patients travel far and wide across the country to get care for this, which I only mention because it just reminds you how specialized the care is. So really do seek that out if it might be relevant for you.
All right. Terrific.
There was a question that might best be directed to you, Anjali, about mechanical risk factors were mentioned, but are there things I can do to minimize the risk of CTEPH if I have those mechanical risk factors?
That's a great question. And that's you're not going to love my answer, because there isn't a whole lot you can do to minimize the risk, except, in other words, to proactively minimize a potential risk. So what I would say is, where we are in the field now is that if you have known and developed CTEPH, then I think it's reasonable to look for, do you have fibroids in your uterus? And maybe we can help intervene upon that to prevent it from happening again. If you have known CTEPH, it's reasonable to look and say, are there narrowings of those blood vessels if we can't find any other cause? But we're still learning to see what the interventions should be and if it makes a big impact long term. But it's certainly something that can really help answer those questions when you're experiencing it yourself. The question about if I've had a DVT, especially in the left leg, should I be concerned about CTEPH? I would say you should be concerned about CTEPH if you have symptoms in the chest, like what Gustavo was talking about, short of breath, fatigue, chest pain, some of those symptoms. And then if you've happened to have had a DVT in either leg or a known blood clot anywhere, then that would raise the concern. I hope that helps answer the question a bit.
One thing Catherine, I want to be discussed, I don't think we really talked about it a lot. It just also because it was on the title of our slides, the CTED part. So we talked a lot about CTEPH, the pH part, the lung pressures. Anjali did a great job of showing how the pressures are measured and also how that affects the heart. And that's certainly the vast majority of cases, and certainly the sort of the more serious, life-threatening cases. But there's also a condition that we're seeing more and more in our centers, and that's the CTED part. So they do have the chronic clot part, but they don't have the pH part. So in other words, you have chronic clot on your lung scan, on your CAT scan, even on your angio, but we do that echo, we do that right heart catheter procedure, and your lung pressures are normal or very close to normal. And the right side of the heart on the echo also looks normal. And then you're like, all right, well, are the clots the reason for my shortness of breath? Is there something else going on? And the answer is it could still be the clots, even without lung pressure elevation. And to tease that out, to figure that out, we will do exercise testing. So we will make you exercise while we measure your oxygen consumption and other things, while we measure that pressure in the lungs. And we know, Anjali and I and Bill and other folks, they do this, we know what patterns are related to clots. So we know what looks like to be short of breath from clots when the lung pressures are normal without exercise. And for those people, we can offer treatment options to relieve the sensation of shortness of breath and some other symptoms, even if your echo and your right heart catheter are normal. So I think that's an important part to discuss, to remember. That's the CTED part without the pH part.
Yeah, Gustavo, you took the words out of my mouth. So I'm so glad you brought that up. And just for the audience, that was a wonderful description he just gave of something very complex. And so thank you for doing that. We're at Philadelphia here at Temple, and we do a lot of that exercise testing too. And so I'm so glad you mentioned that. And we're happy, like Gustavo said, we review cases from all over the country, and we're happy to help weigh in and guide folks, before traveling necessarily. And so anything we can do to help. Yeah.
Although I promised I wouldn't, thank you, Anjali. Although I promised I wouldn't say much with this webinar, I do want to thank Dr. Vaidya and Dr. Heresi for their wonderful presentation and for really providing a tremendous amount of information to patients who have experienced pulmonary embolic events here. And I think this was a wonderful webinar. But I also wanted to emphasize that to all of you out there that we're really all here for you. And there's a growing number of centers throughout the United States. There's Dr. Vaidya in Philadelphia, Dr. Heresi in Cleveland at Cleveland Clinic with a tremendous amount of expertise in chronic thromboembolic disease. And they presented to you how we try to sort these things out. And I also don't want any of you to be left with the impression, oh goodness, I've had an acute pulmonary embolism and now I got to worry about something else. That if you are an individual that does develop chronic thromboembolic disease, the CTED that Dr. Heresi just explained, or CTEPH, there's so much that can be done to help fix this, relieve your symptoms, get you better. And so this is a very important diagnosis to recognize, and there's plenty of opportunity for effective treatment if you do happen to develop this long-term complication from acute pulmonary embolism.
Well said, Dr. Ajay. And just on that note, the next webinar we're going to be having in this series is going to be focusing on treatments. And Dr. Rich Chanik and Dr. Todd Bull are going to be joining us to talk through different treatment options. And again, seriously, Dr. Heresi and Dr. Vaidya, thank you so much. This was wonderful. Thank you, Dr. Ajay, for arranging this. And we really appreciate you guys and all your hard work. So thank you so much.